Hypertension is defined as an office blood pressure, BP, of 140 over 90 millimeters of mercury or above, typically at least twice, taken on 2 separate days. Normal, less than 120 over 80 millimeters of mercury. Borderline, 120 to 139 over 80 to 89 millimeters of mercury. Hypertension, 140 over 90 millimeters of mercury. Out-of-office BP measurements are recommended to confirm the diagnosis of hypertension, with ambulatory blood pressure monitoring, ABPM, as the preferred method, and home blood pressure monitoring, HBPM, as an acceptable alternative. Among adult Filipinos, what are the blood pressure thresholds for treatment and BP targets for the prevention of cardiovascular disease? A therapeutic threshold of 140 over 90 millimeters of mercury to achieve a goal of less than 130 over 80 millimeters of mercury is recommended for most adults with hypertension. For the very elderly, defined as 80 years old and above, a therapeutic threshold of 150 over 90 millimeters of mercury to achieve a goal BP of less than 140 over 90 millimeters of mercury is recommended for persons with hypertension. Lifestyle modification remains the cornerstone for the management of hypertension. Lifestyle modifications should include the following: sodium restriction to as low as 1,500 milligrams per day. The American Heart Association recommends that sodium intake be limited to 2,300 milligrams per day, about roughly half a teaspoon of table salt, in most healthy individuals, and 1,500 milligrams per day in people with prehypertension or hypertension. Dietary approaches to stop hypertension, DASH, meal plan, which is low in sodium and high in dietary potassium, can be recommended for all patients with hypertension without renal insufficiency. The DASH diet is rich in fruits, vegetables, low-fat dairy, fish, whole grains, fiber, potassium, and other minerals at recommended levels, and low in red and processed meat, sugar-sweetened foods and drinks, saturated fat, cholesterol, and sodium. Aerobic physical activity and dynamic resistance exercises, abstinence from alcohol or moderate alcohol intake, significant weight loss of greater than 5% of the baseline weight for those who are overweight or obese, smoking cessation among adult Filipinos for prevention of cardiovascular diseases. Among persons with uncomplicated hypertension, suitable first-line antihypertensive drugs either as monotherapy or combination, ACE inhibitors or ARBs, calcium channel blockers, thiazide or thiazide-like diuretics. Ideal combination therapy includes renin-angiotensin system blocker with calcium channel blocker or thiazide or thiazide-like diuretics. ACE inhibitors and ARBs are not recommended to be used in combination. Beta blockers are suitable as initial therapy in hypertensive patients with coronary artery disease, acute coronary syndrome, high sympathetic drive, and pregnant women. Beta blockers for those with congestive heart failure was specified to be bisoprolol, carvedilol, metoprolol succinate, or nebivolol. Among patients with BP greater than 150 over 100 millimeters of mercury or greater than 160 over 100 millimeters of mercury in the elderly, a combination of 2 agents, preferably combination of a renin-angiotensin inhibitor, ARB or ACE-IS, with CCB or diuretic, should be given initially since it is unlikely that any single agent would be sufficient to achieve the BP target. Cardiovascular risk factors include advanced age, greater than 65 years, male gender, increased body weight, BMI greater than 25 kilograms per meter squared, diabetes, high LDL-C greater than 130 milligrams per deciliter, high triglyceride greater than 150 milligrams per deciliter, family history of CVD, family history of hypertension, early onset menopause, smoking, various psychosocial or socioeconomic factors, poverty, hypertension-mediated organ damage, HMOD, LVH with ECG, Moderate severe CKD, EGFR less than 60 milliliters per minute per 1.73 meters squared. Significant comorbid diseases which increase cardiovascular risk with the background of hypertension, previous coronary heart disease, CHD, heart failure, stroke, peripheral vascular disease, atrial fibrillation, CKD stage 3+. 2. Management of hypertension among persons with diabetes of elevated blood pressure. Among persons with diabetes and hypertension, it is recommended that drug therapy, along with lifestyle change, be initiated at a blood pressure of greater than 140 over 90 millimeters of mercury. The threshold for treatment continues to be 140 over 90 millimeters of mercury. Additionally, screening for obstructive sleep apnea may be worthwhile, as randomized studies of people with diabetes have shown that treatment of OSA by CPAP reduces blood pressure among persons with diabetes and hypertension. What are the blood pressure targets for prevention of cardiovascular diseases, mortality, and morbidity? A blood pressure target of less than 130 over 80 millimeters of mercury is recommended for most persons with diabetes and hypertension. However, do not lower down the blood pressure below 120 over 70 millimeters of mercury due to an increased risk for adverse events. While cardiovascular risk reduction, myocardial infarction, CV death, is already significant for BP less than 140 over 90 millimeters of mercury, with no additional benefit for less than 120 millimeters of mercury, a lower blood pressure target of less than 130 over 80 millimeters of mercury has additional benefit for stroke reduction and decreased risk for nephropathy. Among persons with diabetes, what are the preferred drugs for the treatment of hypertension? It is recommended to initiate with a low-dose combination of a renin-angiotensin blocker, ACE or ARB, with a CCB or thiazide-like diuretic, preferably using a single pill combination. The combination of ACE and ARB is not recommended due to a higher risk of hyperkalemia and renal failure. 3. Management of hypertension in persons with chronic kidney disease. The prevalence of hypertension increases from 36% in stage 1 to 84% in chronic kidney disease stage 4 and 5. Needless to say, blood pressure control is fundamental to the care of patients with chronic kidney disease and is relevant at all stages of chronic kidney disease, regardless of underlying cause. Among patients with CKD who are pre-dialysis, what is the level of blood pressure to start pharmacotherapy to prevent cardiovascular complications and renal progression? Patients with blood pressure more than or equal to 140 over 90 millimeters of mercury should have prompt initiation and timely titration of pharmacotherapy to achieve blood pressure goals. Among patients with CKD who are pre-dialysis, what is the target blood pressure to prevent cardiovascular complications and renal progression? For routine office blood pressure measurement, maintain a BP target consistently less than 140 millimeters systolic and less than 90 millimeters diastolic in patients with low risk of cardiovascular disease and CKD grade 4 and 5, or if with adverse effect on intensive target of less than 130 over 80 millimeters of mercury. CKD patients with high cardiovascular risk or CKD grade 3 or earlier is recommended to have a blood pressure target of less than 130 over 80 millimeters of mercury. A systolic BP of less than 120 millimeters of mercury using a standardized office BP measurement is targeted when tolerated among adults with high BP and non-dialysis CKD, ND-CKD. An individualized target is recommended for the following patient populations, and these patient populations, a specialist referral is suggested: diabetic kidney disease patients, CKD grade 4 and 5 ND patients, patients with proteinuria of more than 1 gram per day, individuals with baseline SBP of 120 to 129 millimeters of mercury, those with very low diastolic BP of less than 50 millimeters of mercury with CAD, those with white coat or severe hypertension, stroke patients, those with age less than 50 with low absolute risk for CVD, or those above 90 years of age, very frail patients, those with limited life expectancy, those with symptomatic postural hypotension. If unable to obtain a standardized measure, maintain a BP target consistently less than or equal to 130 mm systolic and less than or equal to 80 mm diastolic in patients with urine albumin excretion of more than 30 mg per 24 hours, unless adverse events occur with achievement of this target.
Among patients with CKD, what is the level of blood pressure to start initiation with 2 antihypertensive drugs to prevent cardiovascular complications and renal progression? Patients with confirmed office-based blood pressure or more than or equal to 160 over 100 millimeters of mercury should, in addition to lifestyle modification, have prompt initiation and timely titration of 2 drugs or a single pill combination of drugs demonstrated to reduce cardiovascular events. A 2-drug combination should consider these mechanisms in the choice of antihypertensives, calcium channel blockers and diuretics to address volume-dependent type of hypertension, and ACE, ARB, and beta blockers for the renin-dependent type. Treatment for hypertension should include drug classes demonstrated to reduce cardiovascular events in patients with CKD, such as ACE inhibitors, angiotensin receptor blockers, thiazide-like diuretics, and dihydropyridine calcium channel blockers. Among patients with CKD with albuminuria or proteinuria, what is the antihypertensive of choice to prevent cardiovascular complications and renal progression? An ACE inhibitor or angiotensin receptor blocker at maximally tolerated dose is the recommended first-line treatment for hypertension in CKD patients with urinary albumin to creatinine ratio more than or equal to 30 mg per gram or equivalent. If one class is not tolerated, the other is substituted. These medications should not be discontinued unless serum creatinine level rise above 30% over baseline during the first 2 months of treatment, or hyperkalemia, serum potassium level greater than or equal to 5.6 millimoles per liter. If the patient is intolerant to both ACE inhibitor and angiotensin receptor blocker, a non-dihydropyridine calcium channel blocker, verapamil or diltiazem, may be used as first-line treatment in this setting. Combinations of ACE inhibitor and angiotensin receptor blocker and of ACE inhibitors or angiotensin receptor blockers with direct renin inhibitors should not be used. Among patients with CKD with resistant hypertension, is the addition of mineralocorticoid receptor antagonist beneficial in reducing albuminuria and cardiovascular events? CKD patients with resistant hypertension not meeting blood pressure targets on 3 classes of antihypertensive medications, including diuretic, should be considered for mineralocorticoid receptor antagonist therapy. Among patients with CKD, is giving antihypertensive at bedtime more beneficial in reducing cardiovascular events? Administer 1 or more antihypertensive medications at bedtime. Blood pressure management among persons with stroke. The relationship between hypertension and stroke is very dynamic and multifaceted. Management of hypertension during the acute onset of stroke, whether ischemic or hemorrhagic, and during the secondary prevention phase, poses a challenge due to the intricacies of how elevated BP must be handled. For adults with acute ischemic stroke, AIS, who are eligible for intravenous thrombolysis but not for mechanical thrombectomy, what is the threshold for pharmacologic treatment and the target blood pressure, BP? For adults with AIS who are eligible for IV thrombolysis but not for mechanical thrombectomy, a referral to a neurologist or stroke specialist is advised. It is recommended that the BP be maintained less than 185 over 110 millimeters of mercury prior to treatment and during infusion. For the next 24 hours after treatment is given, the BP is recommended to be maintained less than 180 over 105 millimeters of mercury. For adults with AIS who are not eligible for IV thrombolysis or mechanical thrombectomy, what is the target mean arterial pressure, MAP, and threshold for pharmacologic treatment? For adults with AIS who are not eligible for IV thrombolysis or mechanical thrombectomy, it is recommended to maintain a target mean arterial pressure (MAP) of 110 to 130 millimeters of mercury. For adults with AIS who are not eligible for IV thrombolysis or mechanical thrombectomy, the threshold for urgent antihypertensive treatment is with severe hypertension of systolic blood pressure greater than 220 millimeters of Hg or diastolic blood pressure greater than 120 millimeters of Hg. If with severe hypertension, it might be reasonable to reduce the BP by 15% during the first 24 hours after the onset of stroke. For adults with AIS who are not eligible for IV thrombolysis or mechanical thrombectomy, what pharmacologic agent may be used to achieve target BP when needed? For adults with AIS who are not eligible for IV thrombolysis or mechanical thrombectomy, the use of IV nicardipine to achieve the target BP may be considered. For adult patients with acute hypertensive parenchymal intracerebral hemorrhage, ICH, what is the threshold for BP lowering in the first few hours upon presentation at the emergency room? For adult patients with ICH, the threshold for BP lowering is SBP greater than 180 millimeters of Hg. What would be the target BP when lowering the blood pressure in acute ICH? The target SBP is less than 180 millimeters of Hg. In patients with SBP greater than 180 millimeters of Hg, careful BP lowering to 140 to 160 millimeters of Hg should be considered. The magnitude of BP reduction is dependent on the clinical context. It should be careful SBP lowering, avoiding reductions greater than 60 millimeters of Hg in 1 hour. It is also recommended to not lower the BP acutely to less than 140 millimeters of Hg. What are the pharmacologic agents of choice and manner of administration? It is recommended to use intravenous antihypertensive agents that can easily be titrated to lower the BP to the desired level. The first-line drug of choice is intravenous nicardipine. Alternative treatment choice would be intravenous labetalol, when available. For adults who have a history of stroke, what is the target blood pressure level for secondary prevention? For adults with a history of stroke, the target blood pressure level for secondary prevention is less than or equal to 130/80 millimeters of Hg. RAS blockers, CCBs, and thiazide diuretics remain to be the first-line pharmacologic agents in hypertension management for secondary stroke prevention. A patient with a history of stroke will most likely have another stroke in his lifetime. Hypertension remains the most important risk factor for both ischemic and hemorrhagic strokes. Therefore, adequate BP control plays a significant role in secondary stroke prevention. In AIS, eligible for IV thrombolysis but not for mechanical thrombectomy, the BP threshold for initiating pharmacotherapy is greater than 185/110 millimeters of Hg. The BP targets is less than 185/110 millimeters of Hg prior to thrombolysis and during infusion, less than 180/105 millimeters of Hg in the next 24 hours. Preferred agents are nicardipine 15 mg per hour IV, titrate up by 2.5 mg per hour every 5 to 15 minutes with maximum of 15 mg per hour. If available, alternative of labetalol 10 mg IV over 1 to 2 minutes, followed by continuous IV infusion of 2 to 8 mg per minute. In AIS, not eligible for IV thrombolysis or mechanical thrombectomy, severe hypertension, the BP threshold for initiating pharmacotherapy is SBP of greater than 220 millimeters of Hg, DBP of greater than 120 millimeters of Hg. The blood pressure target is if with severe hypertension, reduce the BP by 15% during the first 24 hours after the onset of stroke. Preferred agents are IV nicardipine as indicated above. In ICH, the BP threshold for initiating pharmacotherapy is SBP greater than 180 millimeters of Hg. The BP target is less than 180 millimeters of Hg. Careful SBP lowering, avoiding reductions greater than 60 millimeters of Hg in 1 hour, do not lower the BP acutely to less than 140 millimeters of Hg. Preferred agents are first choice IV nicardipine, second choice IV labetalol. For secondary prevention, adults with a history of stroke, the BP threshold for initiating pharmacotherapy is 140 over 90 millimeters of Hg. The blood pressure target is less than or equal to 130 over 80 millimeters of Hg. Preferred agents are first-line RAS blockers, CCBs, and thiazide diuretics.